So good morning, everyone. Welcome to the first membership meeting for Mountains of Hope for 2021. It's a brand new year, and we've got a lot of really exciting things to do. This is a meeting that I have been really looking forward to for a while because today we get to roll out our next 5-year cancer plan, which has been a labor of love from many of you. I'm really looking forward to being able to get there into your hands. But before we get started, I want to just go over a few. Steering committee met yesterday, and I want to retouch on a couple of highlights from our meeting. The first thing is tobacco cessation training is going to be held by the WVU Dental School in May of this year. And Mountains of Hope has 8 scholarships for this training. So if you know someone in your group or in the community that could use tobacco cessation training that would be willing to undergo this training and then implement tobacco cessation where they work or in the community, we still have 8 scholarships that we would love to give away. I see that we have some people that have used those in the past. I know they've been put to good use before, and we're really happy to be able to provide that for the community. So great resource to take advantage of. And we have a lot of really great things coming up in our meeting today. Today, we're going to be addressing issues of cancer survivorship. And this is a topic we've constantly worked on, but we've not really had a focus in our education on for a while. So I'm really excited about opening our eyes to some long-term issues that come up with cancer survivorship. So many times in our lives, when you hear cancer, suddenly the I have to beat cancer comes up into your mind, and then you don't think about the long-term effects of surgery and radiation and chemo. And so those are some of the things that we will actually get to talk with today. And that's a really big opportunity for Mountains of Hope to work with our cancer survivors and help connect them with resources that help them deal with the long-term effects of cancer treatment. So we will be hearing from some speakers about that today. And then as we break out into our work groups, we're going to be asking you in the work groups to look over your aims and strategies in the cancer plan that affect your subgroup, your subcommittee. So as you go in and look at those, think about the goals that we have in mind and the strategies that have been outlined. And if you feel inspiration or you have a vision of, I would love to see Mountains of Hope do this to help meet this goal, then I really want to encourage you to think about a position of leadership, because in April, we will be doing elections again for leadership positions. The positions that are going to be open are chair and chair-elect of the Early Detection Subcommittee. So we'll be looking for 2 leaders to take on new projects there. Prevention chair-elect is going to be open. And then the coalition chair-elect position is going to be open. And Abby Starkey is going to be activating the nomination committee soon. So there'll be some emails that are going out that'll have more details about what that entails. But if you're looking at a chair position, it's a 2-year commitment. A chair-elect position, it's a 4-year commitment. Coalition chair-elect position is a 6-year commitment. You'll have 2 years as co-chair where you get some leadership training and ready to take things on, 2 years as chair when you ascend to that position, and then 2 years as chair emeritus after that. So keep in mind that those are things that are coming up, and look for inspiration today when you check out the cancer plan. So those are some exciting things that are coming up. I do have a little bit of news that's exciting for at least one of our members. The rest of us may feel a little down about it, but our manager, Lauren Hicksenbott, is taking a new position. And so she will be stepping down as Mountains of Hope manager, and we'll be looking for a new manager to come in and help us organize all of our online meetings and our outreach and our communications. And we want to take a moment to just really thank Lauren for these past several years that we've been able to grow and really adapt to all the needs that we've had at that time. So I really appreciate that.
Thanks, Shelley. It's been my pleasure.
I saw in the chat that someone asked where you can get more information about the tobacco scholarships. So right now, that's an email to Lauren. And I think that's all for my notes from yesterday and for what we've got coming up. So without further ado, I'll give these few extra minutes to Summer, and she's going to go over the new 2021 to 2025 cancer plan.
Good morning, everyone. Let me get my screen up. You know, things that we always say now that we're in a pandemic and working from home and doing virtual meetings. All right, so here we go. Start from the beginning. All right, so for those of you who are not familiar with me, my name is Summer Miller, and I serve as the facilitator for the Mountains of Hope Cancer Coalition. I'm looking forward to talking about our new cancer plan, and the topics I'll be focusing on are what is the cancer plan, how it's framed, and ultimately how to use it. All right, so let's get started. So the cancer plan is authored by the Mountains of Hope Cancer Coalition, and it serves as the framework for addressing cancer in West Virginia. It is used to enhance communication throughout the state's cancer community, to maximize limited resources, identify gaps in services, decrease duplication of efforts, and identify common challenges in the fight against cancer. As you can see in this visual, the cancer plan is grounded in 4 guiding principles. Those are partnerships, health equity, policy systems and environmental change, and evaluation. These principles form the foundation of our work in MOH in the priority areas of prevention, early detection, and quality of life. So some of you may be new, and with that in mind, what does prevention, early detection, and quality of life mean for Mountains of Hope? Well, prevention is the practice of taking action to lower the risk of getting cancer. Early detection refers to measures taken to diagnose cancer as early as possible when the disease is easiest to treat. And quality of life focuses on the health and well-being of a person and their caregivers from the point of diagnosis through treatment and until the end of life. Let's talk about aims, objectives, and strategies. Each priority area, prevention, early detection, and quality of life, has a list of aims in the cancer plan. The aims serve as an overarching topic area that provides stakeholders with a common set of objectives to center their work. The objectives relate to specific data or activities that will help meet the overarching aim. Many of these objectives are listed in the cancer plan, will include population level data, and provide a specific 5-year target for the state of West Virginia to achieve. Finally, the strategies offer ways to meet the specific aims and objectives within the cancer plan. The strategies listed are not meant to be the end-all, be-all list of activities that can be done to meet the objectives. They merely serve as examples of what can be done by individuals and groups. That's a lot of information to throw at you. So let's look at an example of aim 1 in the cancer plan. First, I want to orient you to some key features of the new cancer plan. When you open the hard copy of the cancer plan, you will see this 2-page spread for each aim. At the top of the document, you can see a ribbon of teal, green, and blue. You'll notice that this page has the word prevention in the teal box. This tells you that the aim falls within the prevention priority area. Early detection aims will have early detection in the green color, and quality of life will have quality of life in the blue color. I will show an example of that in a few minutes. Next, you'll see the aims and objectives are on the left-hand side of the book, while the strategies are listed on the right-hand side. One new feature of the cancer plan is how we represented those strategies. So let's dive a little bit deeper. Strategies are broken out by 5 different groups, and each group is represented by a specific icon. As you can see, the 5 groups are West Virginians, healthcare providers and organizations, businesses and employers, government, and community and faith-based organizations. Now, some of you may be wondering, where exactly do you fit within those groups? If so, that's where this page will come in handy. The purpose of this guide is to help users identify where they fit within the cancer plan. Here you'll see one of those 5 icons listed by each subgroup. This will help you quickly identify which strategies to look at when you're on the actual AIM pages. One thing to note is you may fall within several of these categories. For example, someone could be a West Virginian, a cancer survivor, and a healthcare provider. So there are multiple ways this person could help us meet the cancer plan. As a West Virginian, they could join MOH and avoid tobacco use. As a cancer survivor, they could join an advocacy group to help improve survivor experiences. And as a healthcare provider, they could ensure their patients are screened according to the USPSTF guidelines, or refer patients to nutrition or physical activity programs. As you can see, there are a variety of ways to interact with this cancer plan. All right, so let's get back to AIM 1. Here you can see AIM 1 focuses on reducing the incidence and mortality of tobacco-related cancers. Let's say you are an employer, and after looking at these objectives, you decide, hey, I want to work on decreasing the number of adults who smoke cigarettes. And you currently work someplace that is not tobacco-free. Well, where do you start? There are several options. So based on the strategies listed in this cancer plan, you could become a tobacco-free worksite. You could offer incentives for your employees who are tobacco-free, such as additional paid time off or insurance discounts, or you could offer freedom from smoking or other evidence-based cessation programs at your worksite. Speaking of freedom from smoking, you'll notice that it is underlined and italicized. In the electronic version of this cancer plan, you will be able to click that link and it will take you to the website for some more information. Let's say you don't want to do any of these options. Instead, you would rather do a targeted campaign among your staff to educate them on the risks of smoking, the benefits of quitting, and some existing resources that you already have. Would that count as an effort to address the same objective, even though it's not currently listed as a strategy? Yes, absolutely. Remember how I said the strategies listed are not all inclusive of what you can do to reduce the burden of cancer to help meet these aims and objectives. All right. Now let's take a look at an early detection aim. Remember that blue ribbon, that ribbon at the top I mentioned earlier? Early detection is now in the green box, and that helps you identify that it's an early detection aim. Let's say that you're a medical provider that wants to decrease the incidence of late-stage breast cancer diagnoses in West Virginia. As an individual provider, you could provide one-on-one education sessions with women to discuss the importance of screening and when they should begin their screenings. As a health system, you could implement an evidence-based intervention called client reminders. Client reminders can take many forms, and they include phone calls, letters, electronic messages, or postcards to remind patients that they are due for their screening. One thing to note, for all of the screening cancers that are included in the cancer plan, we followed the age groups that are listed by the USPSTF guidelines. All right, last example. Here you can see quality of life is written in the blue text, blue box at the top. So this lets you know that it's a quality of life focus area. The objectives in this aim are a little different compared to most of the other aims. Instead of being focused on population level data, most of these objectives are focused on implementing standards of care promoted through the Commission on Cancer. So let's say you only fall within the West Virginia category of this aim. What can you do to help us meet this? Well, first and foremost, you can use your voice. As a West Virginian, you can advocate for the increased access to quality cancer care. You can also educate your family and your friends who are diagnosed with cancer to look into clinical trials in their area, or you can serve on a community advisory board that is focused on cancer issues. Some additional features of the cancer plan include a brief description of risk factors in the burden of cancer in West Virginia, the importance of integration across chronic disease and other programs to reduce the impact of cancer, how the socio-ecological model can be used to address the wide range of factors that influence cancer prevention, early detection, and quality of life, information about specific Mountains of Hope resources, and an appendix with brief descriptions of the programs listed throughout the cancer plan. All right. Now, many of you are probably wondering how you can get your own copy of this cancer plan. You can currently access the 2021-2025 cancer plan on the MOH website. Due to the size of the document, it may take a minute or two to fully upload on the website. I also want to share that we are currently working with the Center for Excellence in Disabilities to make our online cancer plan ADA compliant. Additionally, we have submitted our cancer plan for printing, and we anticipate hard copies of the cancer plan to be available in February. We have created an online order form where you can request a copy for free, and we will be hosting it on the MOH website. Information on how to access this order form will be sent out via the MOH listserv, and we will have a slide up during our breaks today where you can access that order form. And finally, I'd like to offer a special thank you to everyone who served on the Cancer Plan Committee, as well as those who took the time to review and provide feedback. If we have time available, I'm happy to take questions. Otherwise, please feel free to send me an email at the address that is listed on the screen. Thank you.
So we have a few minutes to take questions if anyone has questions about the cancer plan, how it's laid out, or how it can be used.
I have a question about how we disseminate the information to employers and businesses. Is there a way that we can get a link to them or get information to them about how they can help implement those strategies?
Yes, so you can share the Mountains of Hope website with employers and businesses, and that will give them access to all the resources of Mountains of Hope, including the cancer plan. So we have the old cancer plan on there right now. We'll have the new cancer plan up. That also has the link to our West Virginia Cancer Resource project, and then even some implementation projects around awareness months like lung cancer screening and breast cancer screening awareness months. You can
All
have,
of that's up.
Yeah,
Shelley.
I guess I understand that the partners can do that, but I was wondering if there was any other way we were reaching. I mean, like, I don't have a connection with Walmart, but is anybody going to be reaching out to them to see if they could work with their
with things.
employees?
This is kind of a two-part question for me because in my role with Mountains of Hope, I'm absolutely willing to reach out and talk to employers about this. In my day-to-day normal position, I work for the West Virginia Breast and Cervical Cancer Screening Program, specifically doing outreach and work for screening with employers. So if there's an employer that you think would be interested in doing this, you can have them contact me, and I'll share my email in the chat, and I'd be willing to reach out on behalf of both Mountains of Hope and BCCSP to work with them.
So this is Susan. I'm along the lines of dissemination and how do you build the capacity and use of it. And I'm just even wondering about, can you hold a consortium of employers across the state to introduce the plan to via a webinar or something? I mean, that would be, I don't know if there would be a response to it, but if you could get it out to more people through some kind of, collaborative event or something.
Susan, I was thinking the same thing, listening to Chris ask the question, do we need to think broader for dissemination purposes and tie that to membership? So maybe it's something that the membership committee could work with another ad hoc committee to do something, some bigger splash with maybe businesses and faith-based org. I mean, I just think we have an opportunity to hit nonprofits, businesses, if we'd offer a couple of online kind of rollouts. It wouldn't have to be long. It could be sort of Summer's presentation and some discussion on how it could be best used out in the community.
Maybe through HR people that are working with wellness plans and so forth. They might attend a webinar.
That sounds like a great idea.
If you do something with HR, like if you do, I know that there are a couple SHRM chapters, which is the Society of Human Resource Management. And they often will be looking for presenters for their meetings. And so that might be a great option. I know there's one in Charleston. There's a Mid-Ohio Valley one. I think it meets in Marietta, but it has a lot of West Virginia, organizations in it. And I'm sure that there's another like towards Morgantown, so that might be a great resource.
I love all of these suggestions. These are great.
Another two options for our area in the Wood County area, there is a community health coalition. There's two community health coalitions. One's called the Health Coalition and the other one's called Community Resources, I think. But they hit on a lot of organizations that would be able to use the information.
Sarah, if you could send some of that information directly, like in an email, that would be super helpful, because I do think it's going to be important, you know, for us to get this information out. And typically we would have a bigger production, you know, with our in-person meeting, and, you know, with the pandemic, it's always been challenging. So I definitely would love some of those contacts and information that you have.
So this is Stephanie. I just want to
I'm
say,
sorry, I
this
had
is
to step away, but
this is like my fourth, I think the fourth cancer plan. And I think I want to challenge all of the members, not just the steering committee or the staff. Like, let's keep this a living document. Let's not have it, you know, a lot of work went into it, a lot of time and effort. Let's not have it sit on a shelf. And that's really important for all of us as members, not just leadership.
Absolutely. Susan?
I also want, I wanted to add that I missed a couple comments, but the West Virginia Chamber of Commerce might be a place to go to. And I noticed that they're holding telehealth town hall meetings right now, and they're focusing, but you can see they're looking at health issues. So it could be a time also to introduce this. I don't know who a contact would be there, but maybe exploring their website is a way to go there. I'll see what I can find.
Great, thank you.
I love that we've introduced the cancer plan, and already we've gotten a lot of really good feedback of who can use this document. The usefulness of this document is something that I'm extremely proud of, the work that went into making this user-friendly and workable. So that's exciting.
How do we collect how it is being used in the state? Like, do we have a good collection mechanism to get feedback on when people use it? Because I reference it when I write grants and stuff, but I'm not sure that you would ever know that. I mean, I get the grants, maybe, but you know, you may not know that I used it as a resource.
Actually, that's a place where we could use some more feedback and be able to collect that information, because we know that the people that apply for Mountains of Hope mini grants use the cancer plan. We do know that some of our partners use the cancer plan when they're moving forward with, especially with grant writing, but we don't know if our communities are using that, except for we're tracking the people that can click on it on the website is one way we've been following it. But I'd love to get success stories about how people use the cancer plan, and then we're able to implement something and how that cancer plan really impacted their work. Those stories are like gold to Mountains of Hope, because they help us tell CDC the story of how their funding is coming into the state and being used, and that usefulness is impacting our community lives on a real level. And that's the type of data and information that people really need right now. So
do you collect email addresses then when people download it?
no.
Because that might be a great way, like if you capture an email address when people download it, the primary purpose for that email address might be to send something at the end of the year to see how you have impacted, how your organization has helped impact the progress towards on the cancer plan.
Sarah, if you are techie enough to tell me how to set that up, I would love to know.
I'm not, but WVU and WVUP have lots of students and professors who know how to do it.
But
I'm good at networking.
Stephanie points out a good point that, you know, writing up a success story for the work that you're doing is something that we should look at too, Sarah. So
I'm always willing to write it.
Excellent.
You have to remind me though.
No problem. Okay. Well, I thank you all for the great, robust conversation. How to excitedly share this document with the world is a great way to kick off the year. And I think we'll go ahead and move on to our first speaker. So Dr. Jeffson Chung is a head and neck and reconstructive surgeon at WVU. He completed his residency in head and neck surgery at the University of Ottawa in Canada, followed by fellowship and advanced reconstructions at the University of Alberta. He has expertise in the treatment of oral and oropharyngeal cancers using the latest technologies, which include robotic surgery, virtual surgical planning, and dental rehabilitation. He also treats other cancers such as larynx, thyroid, and skin cancer. He has interests in improving the functional outcomes and quality of life in cancer patients after their cancer treatments. And getting to meet Dr. Chung has been one of the best emails that I've had during the pandemic, as it led to one of my favorite quotes about Mountains of Hope. And that was, you know, I'd almost given up hope that my skills could be useful to anyone. And here I go and find that there's a whole mountain of it. So without further ado, I'd like to introduce Dr. Chung.
Thank you so much. Can you guys hear me okay?
Yes.
Okay, great. So I'm going to go ahead and share my screen now. Whoop. Can you guys see that okay?
Looks good.
All right, very good. So thank you all. Well, you know what? I'm going to just stop that for now. Okay. So again, thank you for giving me the opportunity to speak to you guys today. I especially want to thank Shelley Dusich for approaching me in the first place and making me aware of the Mountains of Hope Cancer Coalition. So thank you so much. Like she said, I am a head and neck surgeon at WVU, which means I treat oral cavity and oropharyngeal cancers. And that's what I would, whoa, what's happening? Sorry. There we go. Okay, so that's what I would like to talk to you guys about today. Okay, I want to talk about what are oral cavity and what are oropharyngeal cancers and how they are different. And I want to talk to you guys about the scope of the problem, how we treat these cancers, and how we can improve on it and improve the lives of our cancer patients. Can you guys see my markings? Okay. Yeah, okay.
Yes.
All right. Perfect. And just a word of warning, I do have intraoperative photos. So if you're queasy about that kind of stuff, just be warned. I will give you a heads up about that coming up. So what are oral cavity and oropharyngeal cancers? So the oral cavity refers to this anterior part of the mouth, okay? It contains things that you would normally associate with the mouth, like teeth, your tongue, your jaw, the inside of your cheek, and so on and so forth. Whereas the oral pharynx refers to this area behind the mouth, okay? And it includes things like your tonsils, okay? And this very far back of the tongue, which we call the tongue base. So these are some examples. This is a cancer on the jaw, okay? So this is an oral cancer. This here is a cancer on the tonsil. And so this is an oropharyngeal cancer. Now, even though oral and oropharyngeal cancers sound so similar, and despite the fact that they're so close to each other, they're actually very different. So if you look at oral cancer, the vast majority of them are caused by smoking. Whereas for oropharyngeal cancer, it's the HPV virus. They're also very different in terms of their symptoms. So oral cavity cancer tends to present as a painful ulcer in the mouth. It causes difficulty with eating, swallowing, and it can affect your speech. Conversely, oropharyngeal cancers oftentimes are asymptomatic and oftentimes will present with a mass in the neck as the first sign. And if you look at prognosis, they're also very different. For oral cavity cancer, I would say the prognosis is about fair. The 5-year survival for advanced oral cavity cancer is probably on the order of about 60%. Whereas for oropharyngeal cancer, that number is closer to about 90%. So what is the scope of the problem? And I am going to use data from the American Cancer Society. Oral cavity and pharyngeal cancer is actually within the top 10 most common cancers in men. Okay, it is not in the top 10 for women, and it is not in the top 10 in terms of mortality for either. The incidence in the United States is about 50,000 new cases a year. And just to put that in perspective, I've included some of the more common cancers. So this is lung cancer, breast cancer, and prostate cancer. And they number on the order of about 200,000 a year. So that just helps put things in perspective. Now, believe it or not, oral cavity and oropharyngeal cancer disproportionately affects West Virginia more than the rest of the US. I'm gonna show you this with data from the West Virginia Cancer Burden Report. But this just goes to show that we should be prioritizing this type of cancer. So if you look at the incidence, the United States as a whole is down here and West Virginia is here. So we have a higher incidence than the rest of the country. And if you look at certain counties, we nearly doubled the national average. It's also one of the fastest rising cancers in West Virginia. Okay, so if you look at oral cancer here, okay, we are very much within the red in terms of increasing rates. Now, we are thankfully very good at treating it. And so despite the increasing incidence, we are actually about stable or maybe even decreasing in terms of mortality for oral cancer, oral and oropharyngeal cancer. So let's talk a little bit about treatment, and I'm going to start with oropharyngeal cancers. Oropharyngeal cancer sees the most amount of research in the head and neck field because it's the fastest growing. This is from a paper looking at the National Cancer Database, and you can see that the incidence has just about doubled over the last 10 or so years. And so it commands a lot of attention. And these are just some of the major trials that are underway or have recently completed trying to investigate how to treat this cancer. But like I said before, the prognosis is very good. Okay, so this is a typical kind of survival curve for patients treated with chemotherapy and radiation. That's the kind of curve you want to see for cancer. And we also get excellent results with surgery. So this is a multi-institutional study looking at transoral robotic surgery. And again, you can see that survival is very good. And it's results like this that's kind of driving the surgical robotics industry in my field. And so here at WVU, we got 4 of us head and neck surgeons who are trained in minimally invasive transoral robotic surgery. You got here, this is Dr. Megan Turner. This is Rusha Patel. This is Bill Stokes. And that's me. And recently, we just acquired the newest model of the robot. This is the SP robot. And Dr. Turner and I just completed our first case earlier this month. Sorry for that shameless plug. So now, where do we go from here? Because we seem to be doing a pretty good job. How do we improve things for West Virginians, given that we are so good already at fighting oropharyngeal cancer? Well, how about we try and prevent them in the first place? Like I said earlier, the majority of oropharyngeal cancers are caused by the HPV virus. And so if we can prevent people from getting it, we can really take a chunk out of oropharyngeal cancer. In 2017, there was this major study that showed that oropharyngeal cancer has overtaken cervical cancer as the most common HPV-related cancer. And this was covered in all kinds of mainstream news. The New York Times, this is Time Magazine, CNN, Reuters, it was all over the place. And the paper estimated that a staggering 1 in 9 men in the US have oral HPV. This is also from the West Virginia Cancer Burden Report. And as you can see, amongst women, cervical cancer is now second to oropharyngeal cancer for HPV-related cancers. In men, it's no contest. It's the it's the HPV show here. So what is going on? Well, it's likely due to the HPV vaccine. Now, truthfully, it'll likely be decades before we can definitively prove that, vaccine is stamping out the cancer. But recent studies are already starting to suggest this. So the American Cancer Society, recently posted this: cervical precancers drop since introduction of HPV vaccine. And they refer to this study. What they saw was that since 2006, with the introduction of the HPV vaccine against HPV 16 and 18, we're starting to see fewer of these precancers being caused by those strains of the virus. This is a post recently from the National Cancer Institute, okay? Large study confirms that HPV vaccine prevents cervical cancer. And they are referring to this New England Journal Medicine paper. It's a large Swedish study that followed almost 1.7 million women. And what they found was that if you look at the, cervical cancer rates in unvaccinated women, here it is, it's going up like that. But amongst vaccinated women, it's down here. So what we believe is happening is that girls are getting the HPV vaccine and causing cervical cancers to go down. But the lower vaccination rates in boys is making oropharyngeal cancer the fastest rising HPV-related cancer. And this is also from the West Virginia Cancer Burden Report. You can see that West Virginia trails the nation in vaccination for both boys and girls. So something that we can do, I believe, is encourage vaccination for both girls and boys per the CDC guidelines. Okay, and I believe Shelley is leading the charge on this. But if we can get the vaccine covered for boys and girls across all these age ranges, we can go a long way in helping this cause. So I'm going to switch gears now and talk about oral cavity cancer. This is a whole other beast here. And just to warn you guys, I do have intraoperative photos coming up. So if you are queasy, you might want to look away for the next few minutes. So treatment for oral cavity cancer is comparatively straightforward in that surgery is almost always the first-line therapy. Now, when we remove a part of the mouth, we need to reconstruct it, and we typically do this by transferring tissue from elsewhere in the body into the mouth. This is called a free flap surgery. Now, I want to focus today on mandible reconstruction. So when we remove a portion of the jawbone, we will most commonly take a bone from the leg, or the fibula bone, and reconstruct the jaw with that. Okay, so here's a picture coming up. Look away if you're uneasy about this type of thing. So this is a patient of mine who had to have surgery for oral cancer. You can see that we've lifted the neck skin up over the mouth. We've removed a portion of the jawbone, and you can see the tongue through that defect. And so we reconstructed this mandible defect using fibular bone. Okay, you can see it there, and this is what he looked like at the end of the surgery. And this is what he looked like 1.5 months afterwards. I think he looks pretty okay. And he can eat and drink and talk normally. We are increasingly incorporating technology into our surgeries. So this is another patient of mine. We planned his surgery on the computer. Okay, this is our planned reconstruction. And this here was the real world result that we achieved. And as you can see, pretty darn close. And this is that patient during the surgery. As you can see, we use those 3D, those computer models, to create these 3D printed cutting guides. And we use those like miter boxes to make our reconstructions extremely precise. And this is what he looked like 3 months after his surgery. This is another patient of mine that had the same thing done. This is her at the start of the surgery. We've lifted up the neck skin over the mouth. We've removed a portion of the jaw. You can see the tongue through there, and you can see teeth there. This is the fibular bone, okay, with the cutting guide on it, and the reconstruction there. And this is her 9 months after. So as you can see, we are pretty slick at reconstructing jaws, but how can we improve on this? As you can probably guess, your leg bone can't grow teeth. And so while we're pretty good at making a good looking jaw, you won't be able to chew. So here are some examples of a couple of my patients with jaw cancer. Okay, you can see it right there and right there. And you can also see that they have very good teeth. And that's unfortunate because they're going to lose a lot of them when we go and remove the cancer. So this is one of my patients. You can see the planned surgery, the planned reconstruction. She is going to lose almost half of her lower teeth. This is another patient of mine, an unfortunate 17-year-old girl with an aggressive osteosarcoma of the mandible. And as you can see from the planned surgery and reconstruction, she is looking at losing almost all of her lower teeth. Now, I happen to think that dental rehabilitation is extremely important from a functional and quality of life perspective. It impacts eating, speaking, psychosocial well-being, and aesthetics. So just get dentures, right? That's no big deal, right? If you look at this here, this person's missing some teeth on the right side there, and he just gets a denture, and that works pretty well. You see that this conventional denture uses clasps to attach to existing teeth to hold it in place. Now, unfortunately, this type of thing, this conventional denture, doesn't tend to work very well for oral cancer patients. Now, this is an example, a patient of mine. If you don't have teeth to clasp onto, your denture won't be stable. And if you have a flap reconstruction, you oftentimes don't have the ridge to glue your dentures onto either. And so this actual patient of mine went to go see a dentist for dentures, and he was told, sorry, no can do. And so he's unfortunately very frustrated and has no teeth. And this is a known problem with conventional dentures. This is a paper from UCLA. They talk about this review of 32 articles, and dental rehabilitation with conventional prosthesis was only available to a tiny fraction of mandibular reconstructions. And it's because that even though we're very good at these reconstructive techniques, in most instances, they fail to provide adequate support for dental prosthesis. Now, these problems with conventional dentures largely disappear if we use dental implants, okay? So these are examples of dental implants. They're basically metal posts that get installed into the jawbone and the teeth clip onto them. So these work fantastic, even in cancer patients. Here are some examples. So this is from a paper out of the University of Mississippi. You can see the jaw resection and the reconstruction with implants there. And this part is the prosthesis. This is from a French paper. Again, a big cancer or jaw resection and reconstruction. Here are the dental implants. And then here's the prosthesis with teeth. Now, I actually trained with one of the leaders in dental implants for oral cavity cancer. That's Dr. Haiti Cycley at the University of Alberta. And that's me, both sporting a beard. And this is from his paper. You can see here, he's got dental implants installed up here at the roof of the mouth. This here is the dental prosthesis, and that's the final reconstruction there. Looks great. And this is an actual case that I did with him. You can see here, this is the fibular free flap down by the leg. We've got dental implants installed already, and then the dental prosthesis has been attached. And then we transfer that whole construct up into the mouth to give the patient a complete dentition. Now, I was asked if I could provide evidence of improved functional outcomes or quality of life with dental restoration in oral cavity cancer patients. So I'll try. This is a 2008 prospective study of 50 patients in the Netherlands. So they said that fabrication of an implant retained denture did not result in major quality improvements as measured by this ERTC questionnaire, but this questionnaire has less to do about eating and oral health and probably more to do with cancer. By contrast, they did find that wearing an implant retained denture resulted in significant beneficial changes in most oral health impact profile scales and many items of the ERTC head and neck 35 questionnaire, which you can see here. So this is the stuff that has more to do with eating. So you got swallowing there, speech problems, teeth. You got feeding tube, weight loss and weight gain, and all that stuff. And so they went on to conclude that the use of dental implants in the mandible should be considered in every edentulous patient with oral cancer. This is a 2016 study that looked at 52 patients who had fibular free flap and conventional dentures at time 0. Okay, and then they looked at these patients at 6 months and 12 months after implant retained prosthesis. And you can see that according to them, their ERTC quality of life questionnaire, their ERTC head and neck 35 questionnaire, and their oral health impact profile all showed improvements, fairly uniform improvements. And you can see here green indicates statistically significant improvements. This is an interesting 2006 study out of UCLA where they tried to objectively measure masticatory performance by having patients chew some peanuts 20 times, and then they try and they take out all the pieces and try and put it through a sieve. It's an interesting way of doing it. But they found that provision of implant prosthesis permitted patients to masticate on both defect and non-defect sides with significant 14-point gains on the defect side and 10-point gains on the non-defect side. Now, those are just studies looking at implant-borne prostheses in oral cancer patients. There's actually tons and tons more data out there suggesting the superiority of implants over conventional dentures in the non-cancer literature in terms of quality of life and those types of things. But in the interest of time, I'm going to skip over these. I think at the end of the day, it shouldn't take mountains of data to prove that having teeth is better. It's common sense. I'm sure we all have grandparents who have gone and bought dentures because they want teeth. Because obviously teeth is good. And so we should let cancer patients have teeth. But because conventional dentures oftentimes don't work, the choice comes down to, usually dental implants or no teeth. That's the choice. So great, oral cancer patients should get dental implants. What's the problem? Well, the problem is that insurance companies don't cover them because they're regarded as cosmetic rather than functional, which is baloney. And our patients can't afford them. So unfortunately, they usually just go without teeth, which is sad. So you remember this 17-year-old patient of mine, if she survives her cancer, she could go on to live another 60 years without her lower teeth. And to me, that is just tragic. And what's even more tragic is that we have the expertise here in West Virginia to do dental implants. We can do this. When I planned her surgery, I planned them with dental implants in mind, but we didn't install them because she couldn't afford them. So what can we do? Well, one thing we might consider doing is petitioning insurance companies to cover dental implants, kind of the same way they cover breast reconstruction for breast cancer patients. And it can work. My mentor, Dr. Haiti Cycley, he got the Alberta government to cover dental implants for oral cancer patients for the province of Alberta. And so over half of his reconstructions go on to get teeth, where that number is nearly zero almost everywhere else in North America. But it can happen. So so that's more or less what I have for you today. I think it's important for us to try and look at these ways of improving the quality of life of cancer patients after their treatment. And that's all I have to say. Thank you so much for listening.
Thank you, Dr. Chung, for that wonderful presentation. I'm very grateful that you and I have been able to work together on that HPV project. The Prevention Subcommittee of Mountains of Hope has made HPV a priority for years and has done several things to help increase the uptake of HPV vaccination as well. And we had a couple questions come up in the chat. And the first is, does insurance cover the dental implants when this is done? And as a follow-up to that, did Canada cover the cost of dental rehab? And what about other countries? And the thought is that it seems like it would be a good idea for that to be a covered service when prognosis is good.
So the insurance companies don't cover dental implants. In the many years that I've been here, I've been speaking with our oral surgeons about that kind of stuff, because they do dental implants, right? But those are primarily paid out of pocket. As for, but that's not to say that there aren't insurance companies that cover them. I'm sure they do exist. If you look at a lot of the American literature on dental implantation for cancer patients, they're coming out of New York, they're coming out of Mayo, so there definitely are places where it's being done, but it's just not very common. As for Canada, we don't use insurance companies to pay for healthcare in Canada. It's the provincial government that pays for it. And so every provincial government is different. In Alberta, Haiti Cycli, what I think is his probably most significant contribution to the field is to get the Alberta government to pay for them. That is unfortunately not the case for the rest of Canada. And so, everywhere else, it's like here in the US, patients just don't get them. Sorry, I forget the rest. What else did you ask?
No, that pretty much covered it. Because we were looking to see if it's covered and if it had been covered in Canada. Lots of, there was a question about a white paper and moving this into some legislative process. I will say in regards to that, there are a couple folks, including myself and some people from the Quality of Life Committee that are looking at how Mountains of Hope can be involved in policymaking around this opportunity. So we know that legislative action is usually a slow moving boulder, but we're starting to reach out and make those connections so that we can work on that. And if you're interested in getting involved in that work, talk to Lauren Wright with the Quality of Life Subcommittee. So that'll be something that we can work toward in the future. And hopefully Dr. Chung will be able to join us in that or be that expertise call if we need someone to come and talk to folks.
Oh, absolutely. Yeah, this is kind of a passion project of mine. You mentioned earlier, this was something that when I first came here, I was super pumped about doing. But we just couldn't get it done because nobody's paying for them. If we can push for that, that would be great. And this is just a side note, but just earlier this week, we had a patient who went through that surgery who was able to pay for them. So we did that surgery for the first time successfully. It's a long process. So he's still recovering in the hospital. So we'll see, but we are able to do it.
So Shelley, I think we have an example from probably 10 years ago, the clinical trials. Insurance companies were refusing to pay for tests that were sort of standard of care for those people who were participating in clinical trials. And we were able to work with the major cancer center directors across the state, develop a white paper, show cost benefit analysis, return on investment. So if we can have stories about people whose lives are made better because of dental issues, and there are a lot of papers out there about that, and tie that to cancer patients, I think that you could move this agenda forward and it wouldn't have to be at a glacial pace like some other legislative agendas. And involving the State Insurance Commission is key.
That sounds fantastic. The fact that there's a template out there to start with and roll forward is amazing. And Dr. Chung, I encourage you to talk to that patient that just undergone that and ask them if they'd be willing to work with us in talking about their story and how this has impacted them, because we do the conversations about cancer where we do interviews, and we do those through video, and we share those on social media, and those are very impactful. And people in the state really like getting that perspective. So that's something that we'll probably want to work on in the future too.
Yeah, thank you. I obviously can't talk about who he is, but he is a somewhat higher profile patient. And so I have thought about it, and I've actually reached out to WVU marketing already about this. I'm going to wait until he's out of the hospital.
Yes, give him time to recover.
Exactly. So I think once his recovery is complete and he's in the right mind space, I'm going to approach him with marketing to see if he'll help us with this.
And
We did have another, sorry, we did have another question. Susan was wondering, what's the average cost for implants?
Yeah, thanks for that question. That's a difficult question to answer, believe it or not. Shelley knows this because we've been
it's
trying
complex.
we've been trying to nail down the cost for like her project, which is treatment for oropharyngeal cancers. It's weird because there's a whole industry, a whole army of people that their job is to bill insurance companies, and then there's a whole other side of it, the insurance companies that decide how much to pay for it. It's a more complex problem than you might think. But just to put things in perspective, surgery for oral cancer, especially a big surgery that requires this type of reconstruction, it's not a cheap surgery, right? Patients undergo 10, 12 hours of surgery. They go to the ICU for a couple of days, and they're looking at a hospital stay usually of about 2 weeks if everything goes pretty smoothly. So it's easily tens of thousands, if not hundreds of thousands of dollars for the cancer care. So that's just to put things in perspective. As for dental implantation, the typical market cost for dental implants is about $1,000 each. And that does not include the prosthesis that goes on top of them. I don't know, there may be people out there who know somebody who owns dentures and will be able to tell me how much it costs. But I would say probably, if I were to give a ceiling estimate, probably on the order of about 10,000, right? Which I think is a kind of a drop in the bucket compared to the rest of their treatment. That paper that I showed from Haiti Cycli, he actually does talk about cost effectiveness. I didn't include those numbers because it is in the Canadian system, so things are a little bit different. The numbers aren't going to match up exactly.
I think about the earning potential of the 17-year-old you mentioned over a lifetime with teeth versus not teeth. And we know that there's good data out there. And I think if you start comparing that to, yes, these are very expensive surgeries, but if you talk about the potential social determinants of health that are also tied in, you could do a really good, I think, make a strong argument to the legislature that's compelling.
So as I kind of anticipated, this has definitely got people's attention. And I can tell that we have some very passionate people that are interested in getting involved with this. And so we will look at how we can move forward with this in some very meaningful and active ways. But for the sake of time, I do want to thank you very much, Dr. Chung, for presenting to us and move on to our second speaker.
Thank you. Thank you. I look forward to working with all of you.
Sounds great. Dr. Chung really set the stage for us of what those long-term complications from treatment can be. And, for oral cancer and oropharyngeal cancer, being able to eat and have teeth is definitely one of those hurdles that we overcome. But in cancer care in general, even after you have survived cancer, you may be coming out of that with a disability or being differently able than you were in the past and needing some assistance. And that's where our next speaker comes in. Dr. Lesley Cottrell is a developmental psychologist by training. She's a professor of pediatrics and adjunct faculty member in the School of Public Health. She serves as the director of the West Virginia University Center for Excellence in Disabilities, and her research and service focus on family health decision-making. To talk to us about how we can, as Mountains of Hope, connect our survivors with resources that are available and the needs that people have through the Center of Excellence in Disabilities, I would like to welcome Dr. Lesley Cottrell.
On mute. Thanks for having me. I appreciate the opportunity to share a little bit about the center, but also some exciting early conversations that we've had that connect these two conditions, two experiences that an individual might have. So let me, is it okay to share my screen?
Yes. All right, so in putting this together, I thought, what are we really asking about? What are we wanting to look at? And so it's really increasing our personal and systemic capacity, right, for understanding both cancer, the diagnosis, the treatment, and survivorship, but also a disability. And sometimes we can get into, I know on the disability side, while we say that is a really important level that we need to consider in anything we do, we tend to think disability, not really the journey that someone went through to have the disability. So kind of looking at this in terms of what is that relationship? What do we know already between cancer experiences and disabilities? What are the gaps that people have already started to address there, whether it's through programming, through concepts, through their research? What do we already know? What gaps are still there that we really need to continue to work on? And while we're working on that, some of those are pretty large. What resources do we have, particularly in the state with collaborations and what we're already doing, that we could broaden the reach, we could make more connections and things of that sort and have an impact. So just in general, and I might be speaking to the choir, and if so, I apologize, but a lot of this was beneficial to me to go back and look at how are these two things connected in prevalence, but also in the mechanisms between them. So when you look at the relationship between cancer diagnosis and disability, from the disability side, we often go to ADA, right, from the early 70s. And this is the definition. So I wanted to, get everyone on the same page in terms of what they usually utilize. So physical or mental issue that substantially limits one or more of someone's major life activities. And the thing at the bottom, the last bullet I wanted to emphasize, other people think you have such a problem even if you don't have it, right? So there's a perceptual element here that's included in the ADA, and sometimes that'll switch. I'll talk about that in a little bit. Sometimes it's the individual who really doesn't see it as a disability, doesn't want to see it as a disability. But if you phrase it slightly differently and you say, is this a limitation that you didn't have prior? That's a little bit more accepting of it, or others notice it and the individual doesn't. What are major life activities? Here are those that are included within the ADA. They're included in other pieces, so intellectual disabilities, developmental disabilities, learning disabilities. We're really talking today about those that impact daily living skills and psychological skills. And so you can look at the relationship between a cancer experience and a disability, both directions. You can have someone who has a disability who has now been diagnosed with cancer. And there is some literature I'm just going to briefly talk about, particularly when you look at intellectual disabilities and developmental disabilities. How are there differences? What does the literature tell us in terms of their cancer treatment and prognosis? You could also look at it the other way. Someone who, and as Shelley mentioned, someone who's going through that experience of having cancer, who then, as a result, experiences a limitation, a disability. So the first one is really that, and again, less information is out there about this, but someone who has an intellectual developmental disability and who has received a cancer diagnosis and care, the literature tells us that there are several barriers automatically for them. During the course of services, there's a limited acknowledgement of the disability, what they term as unseeing of the disability, or people aren't going because there's a physical inaccessibility. Now we're getting better,
we're getting better with our healthcare, not just with cancer services, but our healthcare and provider facilities in general. But there are still reports of patients not able to access the office or not able to engage in the equipment that's used for treatment or services. So that's still there, and that's what you sometimes see in the literature. The other thing is delivering person-centered cancer care was something that I noted in the literature that was a gap that was increasing, and many people were developing approaches for how to improve that. That's no different than any other area of health sciences, by the way. In terms of medicine in general, we've noted that very little except until you get to your third, fourth, and then residency experiences with someone with an intellectual developmental disability, and how that might change, how that might modify the treatment regimen. So in terms of some disparities in diagnosis and treatment among persons with disabilities for cancer, I'm just going to start with the left. Rarely investigated outcome. So it's not found, there's not a lot of it in the literature. I did pull this retrospective cohort, looking back at data. They took 13,591 individuals with lung cancer who reported disabilities of some sort, and then compared that to 43,809 people who were similar in age and gender to serve as a control, who did not have a disability. And on the right, you see some of the differences. More of the unknown stage for cancer was given for people with severe disabilities, and the prevalence was 13.1 versus 10.3, which the biggest group receiving that were individuals who had communication disabilities or mental and cognitive disability coming in and seeking services or requiring services. PWD is persons with disability. So they are less likely to undergo surgical procedures, chemotherapy, and radiotherapy as well. So just some overarching reviews. Now, what we're talking about here, I just wanted to present that, but what we're really talking about is someone who doesn't begin with a disability, but ends up with some type of different, as Shelley mentioned it very well, different ability after the cancer diagnosis, treatment, and follow-up. So that's the largest piece of my presentation. So again, a couple of things that we know. Compared with people without a history of cancer, adults with cancer report fair to poor health, more chronic conditions of a variety in range of type, and then one or more limitations. Remember those boxes earlier? One or more limitations, and the most common were daily living, other functional disabilities. So many of those relate to work. So we're going to talk about work transition. And then, but those are activities while at work, and then just the inability to go back to work as a result of their health after the experience. And you can see the prevalence there. In terms of the types of disabilities that we see among this population, so again, it's more functional. We do see some cognitive disabilities being reported, and psychological limitations, stress, and the emotional. I think a lot of that is the transition and the change of independence and things of that sort. So the impact on a person's physical, social, and emotional well-being and quality of life is throughout that literature. And again, I'm speaking to the choir. You all have seen that and contributed to that literature. So those are the types of domains. Those are the areas that we really want to focus on for this group. Despite all of this, only 1/3 of patients report cancer as a cause of that disability, which is really interesting. So they might, it might be the result or come out at the end of that journey, but they don't necessarily, only 1/3 really put those together. Now, if you ask others, family members, other caregivers, providers, what consumers believe cause disabilities in general, cancer is on the list, and it's pretty high on the list. It's the yellow bar at the bottom. So of course, serious accidents are there. And of course, we're not talking about developmental or intellectual disabilities. We're talking about this functional disability, the daily living disruption. Stroke is the second, and then cancer is the third. So in other groups, cancer is listed as having a strong relationship there. So as I mentioned, work transition is a big one. You can see here, work disability associated with cancer survivorship. 40% of cancer survivors are of working age. So this is a significant area that we can make a big impact. If we focus on getting them back to the workforce for various reasons, but 40% would potentially be impacted. And many have the question, can I work with cancer? Seems like a very basic question, but that is the common question that's noted in the literature as well. So types of things that they need: support and navigation for seeking disability. Again, sometimes even though we've made that connection, resources aren't there to bring them together. So now they're in a situation where they really need some of the basic background of disability, as well as advocacy pieces, self-advocacy pieces for themselves. Review finances, work, insurance process, all of those that are needed to get them back to a life that they perceive. And those conversations are important to have. They may not want to go back the way it was before the cancer diagnosis and treatment. And that's okay. Identifying what independence is for them, what level of daily living is for them, what is their goal, where they want to be, is the key. And then bringing them resources, helping them navigate the larger piece, the larger system to get them there, is what they're asking for. And then I've already mentioned the transition back to work. In terms of the reports of cancer and timing and disabilities, it's all over the place. The ranges are wide. So you have between 5 to 99% of patients had some form of cancer-related disability. This was done in a review in 2018 of all literature that's looking at cancer and disability. Big ranges across studies in different cultures, and this was an international-based review. Similarly, 10 to 38% of patients had difficulties with activities of daily living. So again, dependent on the population. In West Virginia in general, we have a third of individuals outside of a cancer diagnosis, a third of individuals who have a disability, and the functional disability is the largest group. Okay. So focusing on the functional disability, as well as the psychological distress that we're seeing, is something that we should use as a guide moving forward, nationally, internationally, and as well as a little bit about what we see in West Virginia. So they're getting some of these that you see in that second bullet: information, counseling, physical therapy, help with physical needs, daily living. They're getting that with the medical regimen that's already there. Knowing how we can complement that is going to be important too. What is the way we can focus, for instance, on depression, which you can see the ranges again, they're pretty wide, from 6 to 54.9, and anxiety and PTSD. These are the 3 psychological impairments that are reported, and all but PTSD, and the data weren't there for PTSD, all being highest during treatment. And we can't forget the caregivers. This is very similar. And on our side for disabilities, caregiver respite, caregiver supports, caregiver peer groups, a lot of that's built into our programming within the center. And so these resources here could complement, if desired, could complement and help caregivers who, particularly during treatment even, since that's the highest psychological distress, could help by providing respite and support, in addition to the cancer support groups. So what have we been doing to address some of these things? And again, these were the areas that we have programs here, but they're also high on the list for those who are experiencing cancer and going through that process. So limited access to services, social determinants of health, which is wonderful because that just already came up in Dr. Ching's presentation. Complex needs considerations. So if other things are going on, how to incorporate that into the planning, and not just while in the hospital, but back at home. Work transitions, daily living skills, advocacy and self-advocacy, and then the psychological social distress. The center really looks at, for limited access, really follows, like I said, ADA. And particularly during COVID, a lot of that is becoming telemedicine, telehealth. Sometimes that starts with knowledge, just knowing where you can go in the Health Sciences Center and find an accessible bathroom is important. I've seen the cancer patients in wheelchairs who are going to the female bathroom just near the cancer center on the first floor of Health Sciences who can't get into the bathroom. So we're doing better, but many times we have old buildings, not just throughout our state, that need modification. So limited access, understanding and documenting where things are and where they can go. Offering telemedicine, telehealth, and I think we're doing a great job with that. And for community services, those have started to use that, as well as hybrid with home visiting. So you have your assistive technology, for instance, assessments being done. So someone will go into the house, assess what needs to be, what modifications the home needs so that the individual can maintain independence, can shower, can go from the bedroom to the bathroom. If the door frame needs to be modified, needs a ramp, anything like that, that an assessment can be done in person. And then a lot of the follow-up happen through telehealth and telemedicine. And then the interprofessional work and medical home approaches are just fabulous. So we've had great teams that include a lot of disciplines, OT, PT, medicine, social work, the home visiting, and it depends on the age, the daily living, family resource network, all that whole group goes in and then figures out their approach. This is a little bit more complicated, and it's hard. The social determinants of health, most commonly reported, we have patient navigators who can identify 5 different areas with the idea, and just like Medicaid is doing, with the idea that if we are able to address these areas, perhaps their medical outcomes will improve. And those 5 areas are transportation, keeping utilities on, housing, reducing interpersonal violence, and food insecurity. And the one most impacted is food insecurity at this point with COVID. So the hope and the idea is that these patient navigators can work with the medical team and the rest of the medical home to address those social services and social determinants, and help them make their meeting, or meet their visits, but also comply with other regimens. The other thing is starting to look at, within the disability realm, starting to look at things such as sexual risk decision-making, taking more independence of your own medical record, and developing those skills so that someone can do that. And this is just, I think everyone's familiar with social determinants. The first group that I mentioned, the group that starts with disabilities and then might have a diagnosis, is one that we're really, like I said, they're less likely to obtain mini surgeries. And from the physician side, I don't know if this is across the board, but I do know that for You have individuals with disabilities, intellectual and developmental disabilities, who are 4 times likely to be morbidly obese. And so they are also one of the highest groups to need bariatric surgery. But the surgeons are hesitant because it's difficult to get consent. That process, that familiarity, do you work with the guardian? Do you work with depending on the level? Again, talking about issues such as person first training. How do you talk about the disability and whether it has any effect on the medical condition that an individual is having? Maybe it doesn't, but how do you describe it? That's a training that we provide. We do simulations where we talk about history and physical. If someone has sensory, if they're very sensitive to touch or light, and they're put into a room for history and physical, and someone touches their shoulder, they might react in a negative way. That really makes it difficult to obtain the history and physical. Certain symptoms and conditions might be interpreted one way, like we had ATV and substance use. And in that sense, the focus was on the substance use and the trauma, but less on the traumatic brain injury that resulted from it. So just not treating them separately, bringing them together, and a lot of that is training that's going on. And that includes the patient-centered medical home, because that's complicated to implement. So we review that. Work transitions and skills. So this is the biggest one in the literature. We have at the center a few things going on in this sense. We have the WIPA, the Work Incentive Planning and Assistance Program, that's funded by SSI. And the focus of that is to, if someone has benefits, to help someone obtain benefits if they're eligible. But if they have benefits and they worry that if they go back to work, they'll lose those benefits, they have specialists who will work with them through that process so that they don't, and that they can go back to work. We have communities of practice, and we work with employers on how to adapt the work environment in ways that would allow individuals who, depending on a disability, come back and do a variety of roles in different work settings. In the work area, we have the second highest disability population in the nation, and the lowest, or you can switch it, the highest unemployment rate of those individuals. So there's a lot that we can learn to help with that transition back to the workplace with a disability. We also have a community resource program, which is funded by the Department of Rehabilitation Services. This allows us to do some life skills assessment. So if someone's physical or functional skills have been modified, and perhaps significantly, this life skills assessment goes through that process of what would they like to do? How does that match up with their abilities at this point in time? What kind of a career would bring all of that together? And they answer questions, they take that, and an action plan is developed as a result. Skills development, modifying resume, working with OT/PT as they go through their treatment, if their functional assessment changes over time, and then actual workforce placements in different settings. Of course, ADA comes back and helps a lot in terms of work incentives. And someone who has not had a disability but has recently developed or experienced one through cancer diagnosis and treatment might not be familiar with ADA, or might know what it is, but not the details. And so ADA is pretty structured and pretty helpful in that sense. And it also helps with self-advocacy. An individual will know what is within their rights, what things they can ask for, what they should be looking for. And so it helps with that independence. And to hopefully they don't ever experience this, but discrimination based on their functional ability. So a lot of these skills and assessments that we do include daily living skills, and the CATS index and Lawton IADL scale are common, the most common. When you look at that across, and this is also from the cancer literature, the 3 most common ADLs are personal hygiene, walking and transfers, and then these instrumental ADLs such as housework, shopping, and then transportation's a big. So that kind of goes back to that patient navigator, finding accessible transportation. And then of course, rehabilitative counseling, PT, OT, and the medical team are just key for that piece. Again, another focus, another importance is advocacy for the individual as they go through the process, and then after the process, and then self-advocacy, building over time the ability to know what's going on and being able to navigate alone or primarily by themselves. So increasing, like I said, I already mentioned the program that's looking at taking more, and maybe they're already involved, but being more involved in their healthcare throughout the whole process. Quality of life focus for survivors. Some of the antecedents for a very strong self-advocacy are listed here. So on personal side, their attitude, belief, traits about the experience, their, a lot of this resiliency that we hear about. Here are the descriptions: the drive to overcome, to control, or own the negative experiences, openness to try new things. Communication skills are key, which is why maybe in the previous literature, those with communication disorders might have a harder time. And then attainment of support, so reaching out. This is the biggest one that we see. Of course, having the support network around them in different forms. Lastly, then we try to focus on the psychological and social distress. So we mentioned depression, anxiety, and then there's a PTSD component. And then we don't want to forget the caregivers. Right now, the DD waiver, so if someone obtains disability, there used to be a really healthy support for caregivers for respite. So you could have a nurse come in, there was a wide variety of different ways. That has slowly over time been reduced to where caregivers don't have a lot of opportunity for respite. So that's the policy area that's being a great focus this year. But a lot of our programs include or try to include some respite for the caregivers. And throughout all of these, I can't mention enough about assistive technology. So you have the employment side, you have the psychological distress, you have the, if there are any experiences or changes with perceived independence or change in that role, assistive technology can help with many of those. It's blurry here, but you have a wide variety of no tech, and things of, in a daily, you can't, for someone who can't hold their pencil, they have items that they can put on the pencil so that could be a goal that could help. Slanted services, they have wedges, they have different pieces. Paper, just like our kids use in school, but the lines are slightly raised. That helps with visual, that helps with tactile. Magnifying bars, weighted pencils to help with fine motor, a wide variety. Low tech, you see some of those buzzers. If someone's fine motor has also been modified and they can't flip a switch or they can't twist a knob, they have all kinds of things to modify that and put on light bulbs or to put on light switches, to put on any type of thing in the kitchen, in the bathroom, in the bedroom. Again, it's a slight change, but it brings independence so that they don't have to ask someone else to do it for them. And these items can be loaned. They vary in price. So before someone pays, particularly for these high-tech items in the figure, before someone pays for a high price, they can loan it for a few months. See how that incorporates into their daily schedule. Does it work? Does it serve the purpose for them? And if so, then they can go back and they can, the staff, the assistive technology staff will help them go through that process, because sometimes they can get it for free or at lower cost. And with the high tech, you have e-readers, touchscreen devices, and all of these can be placed now. You know, you have like Echo and Alexa that turns on the lights for you. So they have those pieces. They have speech recognition software that can go on phones and computers. Every state has an assistive technology group. That's a requirement. Ours is here. We're lucky to have it here. They go in to clinics at the hospital. And again, where needed, they'll do a needs assessment to see what area might be needed, what item might be needed. They'll bring a couple items to see what the individual might want. They'll go back to their home to get a follow-up. And then they'll go through that process so that by the end, the individual has whatever assistance he or she needs. And again, so it's to increase performance, maintain, and improve. And this independence goes significantly into the self-advocacy piece as well, right? And again, it can be used at school, it can be used at work, it can be used at home, wherever. And it's really fun. If anyone ever wants to come and see, they have several demonstration rooms. They have a demonstration kitchen. They have a demonstration living room. They've kind of set up this house. They have a demonstration office where you go in and you see everything, and there's tons of items. So it's really interesting to look at. Obviously, to have one in every state and that being a requirement, there are several benefits, and people are trying to increase the availability of these groups. And I forgot to mention, it does help the autonomy of the individual, but also the family. It serves as a respite for the family as well, contributes to that. Some of them, depending on the items, help with memory, recall. There's a lot of literature out there that it reduces risk around the home. Of course, if you have the bathroom fittings, that alone is an example. It's used a lot to keep people from nursing homes or care homes. If their home is not adapted to their needs. And then it reduces stress from others in the home. So we're doing a lot. We're collectively doing a lot. There's more work that we could be doing with the medical team, with other providers. It seems like from the literature, we personally have not been working with families during treatment. It's been mostly in the transition home. And so maybe that is a great opportunity to do. But in the areas of support for the family, support for the individual, acknowledging and learning more about the disability sides and what skills and resources are available to them, because this is something new in their journey. The importance that disability doesn't necessarily mean limitation. And I think that's the people first language. Disability is really a different ability. So I go back to Shelley's, the way she introduced this. We're just different abilities, different levels, and we'll tailor it based on what we all need. And I think that perception is needed a lot, particularly with someone who reaches that and has not experienced that before. So life doesn't stop. Management options exist. They're not alone. On the disability side, and obviously there's supports from the cancer side. Focus on the family as well, and then consider all settings and try to get them back to work. A lot of these items, and particularly more about assistive technology, is we spent some time, and it was a really great discussion. Lauren coordinated this with us on the podcast. We had a good time talking about it. but we represent more of the work resources as well as the AT resources at the center. And happy to plug that and then answer any questions. Thank you.
Wow, that was amazing. And I thought I was pretty up to speed on some of the resources that we had available. I had no idea how much work and how many resources were together in that. That was fantastic, Lesley. Thank you.
Thank you.
We have some really great comments in the chat. So Stephanie Kennedy Ray talked about how she's recently used assistive device services of the CED for a family member, and it's been really amazing. In particular, the staff there thought of things that they never would have considered. So it's been wonderful to be able to increase the independence of that person who had suffered a serious fall. We also have a comment from Dr. Chung saying that he has a lot of patients that need to use assistive tech, particularly right after their surgery. And so oftentimes they do need writing boards for some communication. And he's used sign language interpreters for his deaf patients.
Wonderful. And we could, we have all kinds of communication boards. So maybe we could set up a meeting and you can see what works, what you want to do. That's great.
Yeah, sorry, I'm going to speak up a little bit. One of the issues is that, you know, our patients, because they may have a temporary tracheostomy tube after their surgery, they can't talk, but they're also not very good at writing. And so they either write very slowly or have just tons of spelling mistakes, or sometimes they get so frustrated with communicating with writing that they give up. So I would be interested in hearing ways to get over that hurdle.
I'll follow up with you. Thank you.
Okay, so I have a daughter who's partially deaf, and yesterday when the Pledge of Allegiance was done during the inauguration ceremony in sign language, I cried almost as much as I just teared up at seeing these bridges being built today between our folks that are our guests coming into Mountains of Hope and those of us that have been here for a while. This is a magical moment when we get to make those connections, and it just makes me really happy. Are there any other questions for Lesley?
Lesley, you may have said this and I had to step out for a minute, but are your services available to everyone across the state?
I didn't say that. Thanks for asking. Yes, this is to everyone. We are part of a 62 center network, and there's at least one UCID in each state. We're the only one. We will serve families and providers wherever you are. The other thing too, and I'll mention just because the AT recreation, and I mean, the domains that they cover, it's just amazing. So let's say someone played the guitar or made music and could no longer do that or was having limitations. They have, or played the piano, they have a synthesizer that uses gross motor and can make very complicated music as a result of gross motor. So here you have another opportunity where someone really, that meant a lot to them to be able to make music in that way, could not do that and could go back. So recreation, I mean, farm equipment that's modified so that they can go back to doing that. I mean, the whole gamut, the whole gamut.
Les, I think what's important for people to know is that whole idea of borrowing, so that you know what's available and like what you're really going to use before you invest in the equipment. And so I think that knowing that there's a lending opportunity is really important for patients, regardless of income level, because you don't want to spend a lot of money on equipment that's just going to sit and gather dust.
Absolutely.
And question, Lesley, for those that are looking at purchasing this equipment, like they've tried it out, they know they like it. Is the facility able to help work that with, say, Medicaid, Medicare, their insurances?
Yes. So the team helps them navigate that. Again, they try to find a cheaper price for the same device, first of all, and then once that's finalized, they'll try all kinds of resources. There are several things, even outside of before you get to insurance, that different scholarships, different donations and things of that sort that have come in to try to help with that. And I put the WVATS, so it's West Virginia Assistive Technology group. I put that in the chat if people want to go to their website.
Lesley, can you speak to, I worked in developmental disabilities in West Virginia for about 10 years with the waiver program. And typically what people don't understand is that Medicare, Medicaid don't typically cover most of these items, correct? Is that still correct?
Most of them. We've had a really good experience with some of the domains, some of the areas that really consistent funding, but not all. And yeah, not all. You're right. And that's really what started the donations.
Yeah, it's shocking when you get into it and you realize there's a limit, you know, just because someone's power wheelchair breaks doesn't mean that they get a new one.
Yes. And oh, I'm so glad you mentioned that. So partly to help with that as well is they have a pay it forward program that they just started. And so that's, if you know, something that's slightly used, still workable, but someone's grown out of, someone's not able to use it for whatever reason, they bring it, they get donations of equipment of a wide variety. They fix it, they get it ready to go, modified, reviewed it, accepted, and then they're able to send that back out. And that goes out, those items go out for free.
That's really awesome, because that's something that we, for years, as service coordinators, we would have all kinds of patients across like the age spectrum. It was like, well, she's too old now, she doesn't need this device, but somebody else might be able to use it. And there was not an exchange program like that. So that's really cool.
Yeah, they have a big garage and they house it.
Okay, well, if there's no other questions for Lesley at this time, Lesley, thank you so much for joining us.
Thank you.
We will go ahead and cut to break and then come back from break at 12:30 when we will break out into our work groups and review your areas of the cancer plan. So take a break, stretch, get up.
We stay logged on, Shelley.
You can stay logged on and just turn your video off if you'd like. And we'll all meet back here at 12:30.
Yeah.
I'm going to.
Want to have a quick look at what we did. And Shauna, I believe you were going to report out for early detection.
Yeah, sure. We went over the aims and we realized that after some discussion that lung cancer is still probably a hot topic for us in West Virginia. One of the things we talked about is there's a lot of cessation programs out there that do not refer their patients or talk to their patients about lung cancer screening. So we talked about that might be a real nice starting point, is to look at these programs and train maybe their facilitators in talking about lung cancer screening and why the people are have a need for it if they are smoking. So that's kind of the big thing we really talked about. Most of our time was spent on that.
Great, thank you. Prevention subcommittee.
Summer was with us and she was very helpful, and we talked about the aims of our group related to the cancer plan. We talked about our aim number 2. We talked about part partnering to try to get folks to eat healthier and some possible ways, and we'll be following up. We have an upcoming opportunity with Nicole Stout from WVU Cancer Institute. So we think that's going to be good opportunity for us. And our education program, we tossed around some ideas on how we can get that up and running and how we can appeal to a wide range of audiences and networking with other groups. And we're going to be meeting on the 26th at 1 p.m. as well.
Quality of life.
So we only got through 2 of our aims because we had a lot of thoughts. So we had somebody, Carrie Wines, actually had an idea about the different COC standards we have included in one of our aims, and trying to make network connections and partnerships among the larger COC hospitals or institutes in the state with the smaller scale who may need some expertise and help, more one-on-one or, group kind of work so that they could help them, so Carrie at CAMC could help somebody in, really rural area of the state, try to figure out how to get some of those COC standards off the ground, ask questions, things like that. So we thought that was a great idea. Then we also we got into our bulk of the time was genetic counseling and genetic testing and tumor typing and just a whole slew of that information. So we came up with different things. CAMC uses Ambry Cares for their genetic counseling testing type of work, and we talked about the different communication barriers and issues between patients and providers when it comes to what they're actually getting tested for, and what that means for them, what that means for their families, insurance issues, lack of information available, missing information or misinformation about like 23andMe. Chris then brought up that point, how that's not a full genetic test, but some people may think that it is. So we have a lot of ideas that we're going to have to narrow down during our meeting next month.
Lots of ideas is not a problem.
It's narrowing down that's going to be the problem.
I love that the cancer plan has already been that kind of inspiring. So if as you were in these work groups and you heard about the aims and you saw the strategies and just thinking about the work that we're looking at going ahead, if you are a person that would like to be helping to facilitate that work, to help make sure that your program happens on time, we get our budgets in, and you're looking at shaping that work, I really do implore you to get in touch with Abby Starkey about taking on a leadership role with Mountains of Hope, because our Cherry Lex and will be coming in for early detection. Hang on, my notes are covered up.
I was going to say it, Shelley. I had them written down here.
Oh,
Coalition co-chair, prevention chair-elect, early detection chair-elect, and the chair for early detection.
yes.
All will be up for election.
So we implore you to look at your availability, at your inspiration, and take this opportunity to put your passion into action. I will say one of the things that the coalition has worked on and the steering committee has worked on is to help provide some support and some educational opportunities for those that are looking to learn leadership skills and learn leadership practices, and those have been very helpful. So that's probably something that we will continue into the future.
We will be sent, I don't know what Shelley said this morning before I got on the call because I was late. But
basically the same thing.
Okay, so there are qualifications, like not super high. There are some qualifications, and mostly has to do with membership and attendance at meetings. And I will be sending those out. And we also really want people that have the time and want to give the time, and as much as you can. I know that things change, sometimes they change rapidly. Commit to the full term. So for subcommittees, terms are 4 years, so 2 years as a co-chair and 2 years as the chair. And then for the coalition, it's 2 years as a co-chair, 2 years or chair-elect, 2 years as the chair, and then 2 years as the chair emeritus. So you're sort of like an advisor to the new chair. So, and we set it up that way because we wanted to have more of a path to leadership within the coalition to give more people an opportunity to lead. So that's, I guess that's all I really have.
If you're
But
if you're new and you're not sure or you have questions, reach out to Abby and ask her, because even though we're talking about qualifications, you know, you maybe want to be more involved in this, might be an opportunity for you too. So.
And yeah, if you want to nominate yourself, you can nominate somebody else. We just ask that you have asked them if they're interested and they feel that they have time. But you don't, yeah, the qualification isn't like you have to have this degree or worked this many years. It really just has to do with some involvement with the coalition and not like a ton. So we really want people, even if you think, I always joke that I was like sort of not voluntold, but like it was hinted like you should do this. And I never, it was said in a meeting and I didn't know that it was being said at me until later. And I was like, oh, they think I can do this. Oh, well, I didn't know. And the first coalition meeting I sat in 3 years ago, I sat in the back of the room by myself because not only was I new to the coalition, I was new to my department. I was new to the university. So I didn't know anyone. And so we were in, used to go to John the 23rd building. And it's a big room where we meet in. It was a lot of space. And there were some tables in the back. And I went and sat back there by myself and someone had to come and get me. So come a long way. So this can be anyone is my point in all of this. This can be you. We can make you loud and aggressive and here to get things done too. Right, Charlie? Right?
Sorry. Yes, absolutely. It just gets me so tickled because it's so hard for me to picture you being that very shy person that you were.
You were there.
Ago.
She doesn't remember, but I didn't know anyone. I was scared. I was surrounded by, people.
I remember.
That were talking a lot. And the first time I had to get up and speak, I was so nervous. And I remember that Stephanie said, these are your friends. These are your people. You know all of these people. You've been at that point, I've been in the coalition for a year. You need to not be, oh my gosh. Oh, it was awful. And now I don't love the public speaking, but it's fine. I can do it. I definitely wouldn't have been rambling on like this 3 years ago. So it was really supposed to just be an example. Someone
so you
cut me
see,
off. Someone cut me off.
behold the power of the power of the coalition and our dedication to investing in you and your leadership skills.
So you can do it. We can help you.
Absolutely.
Yes.
Speaking of helping you, did anyone have any questions or any further discussion about things that happened in the meeting today? If there's not, we're going to give you the gift of time and go ahead and call it a day and let you have the rest of your afternoon back.
You will get a follow-up email from us just for the post-test and evaluation of the meeting. Thank you guys all for joining us.
Thank you.
Bye-bye.
Thanks.
Bye.